Hello, everybody. Welcome to the stream. If you're here, just say hi so that we know that you are watching, because I can't see who's here. I only know the number. Thank you for joining us. Today, we have a very interesting topic. And this is something that not a lot of us spend a lot of time thinking about, not a lot of us spend a lot of time considering it as an option. And this is actually in the work of, in a place called the Hospice. Right? Well, there's this quote by Dame Cicely Saunders, and she says, "You matter because you are. You matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die." Wow. There's a lot of thought that goes into a statement like that. Well, we've sent out the request for questions. I had a total of 53 questions. Wow. And today we're going to answer some of these questions, right? What's it like working in a hospice? Does a professional ever get tired? What are patients like in a hospice? Are they positive? Are they negative? And based on that, let's see what we can learn from our wonderful guests today. Welcome to the 11th episode of Life, Love, and Lipidemia. Hello, everybody. Hi, Raymond. Hi, Mrs. Chan. Oh, my former general manager from the pharmacy. Hi, thank you for joining us. Hi, everyone. If you're here, just say hi so we know you're here. Well, we are live actually on Facebook and YouTube. If you haven't subscribed to the YouTube channel, just go on to the link right there and click subscribe. Today we have a guest. I'm super honored to have him, Dr. Chong Poh Heng. Welcome to the show. So Dr. Chong actually has been working in the hospice sector for a really long time, almost 10 years. And before that, in his own practice, he's been dabbling in this field of hospice. So, well, the first question that I'm really curious to ask you, Dr. Chong, is this. Most of us come into healthcare with the aim or the dream of wanting to help someone, right? To get well, to recover, to get better. Most of us work in a hospital or in a primary care setting. But you chose to specialize in work in a hospice. Why a hospice?
Hi, good afternoon, everybody. It's a big question. So why hospice? But it all goes back to then what's hospice before I can answer why hospice. So I thought I would just tackle that first. Hospice means many things to many different people. And sometimes people, when I ask them what's hospice, they will say it's a place where people go to die. So, but I don't think so. It's a place I believe that, well, it's not really a place, I correct myself. It's a philosophy. It's a spirit of enjoying, treasuring every moment just close to dying before one dies. And it's not a place, mind you, it is, it can be anywhere. It can be in a hospital, it can be in a nursing home, it can be in your own home, and that's the area where I practice. So why hospice? As you mentioned a quote from Dame Cicely Saunders earlier, it's about living until you die. So all of us have an expiry date, and we won't ever know when that date is. It's not stated quite clearly on the bottle, really. Therefore, some of the lucky ones, for example, those who are diagnosed with terminal cancer, and they are given, you've got 3 months, you've got 6 months and all that. Then they get to prepare, then they get to enjoy, then they get to, savor the good things that we give or provide in hospice. So I think it is about enjoying every moment until the very end. So why hospice? All of us need to enjoy ourselves, don't we? Yeah. Every minute we are looking for that gratification, whether is in finance, whether it's in pleasure. But many times when people are in this, time of their life, it's about getting that peace. And I think that's a very precious commodity that we try to sort of engineer or facilitate in hospice. So all of the above, it's about settling some of the practical things. It's about settling some of the, I suppose, social and emotional things, and many times settling the spiritual aspects before one comes to life's closure, moving on to a different space, if you believe there is another space that we get to.
How do you get started in this field? I mean, because that's not something that people, that's not a typical type of work that people start their career in, right? As a professional. Why got you thinking about it at the start?
I didn't get into medicine wanting to do hospice, so it's a very long journey that I've taken. I didn't go into hospice full time until I was, I think, almost 45. As you said, I practiced for more than 10 years now in hospice, so you guys know how old I am at this point in time already. So you're speaking to an old man here. And when I was young, I had my grandfather diagnosed with laryngeal cancer, and I was able to, while I was in medical school, see him go through surgery, see him go through pain and suffering, and see him go through advanced disease. And I was quite disturbed by what I saw, and obviously it was one of those first times in my life where I came quite close to dying or meeting, someone who was dying. I had a pet rabbit that died after drowning in my toilet bowl one day. That was terrible. So it took a long time to get over that. But then this was somebody that I admired very, very much. Somebody I grew up with, and when I had to go through that process of watching him, with the so to speak, day by day, it was hard. And when I saw that this very stoic old man who had never complained about anything in his life cry, or I wouldn't say cry, but shed tears of pain, it was just heartrending. So that was a time when I plucked the courage to go to one of my lecturers in NUS while I was studying in third year medical school, and hunted her down, because I realized that she was the one who was able to put together a cocktail of morphine, which was only just introduced into Singapore that very year. And I happened to hear that it was something that was able to manage pain of any severity. So I went to her and begged her to go and meet my grandfather. And she came to that little rented flat in Dover to meet my grandfather. And in that process, despite being an Angmoh, so she's somebody, Anne Merriman is her name, she's somebody who couldn't speak the language, but connected with my grandfather in a very deep way. And not only did she manage the pain, she was able to bring what I said earlier, that look of peace, on his face as he breathed his last over a couple of visits that she made. Yep. And that left a deep, deep impression in me. I forgot all about it after I accidentally went to medical school, and then went on to do various other things until I revisited some of these memories, and that sort of gradually took me on the path to hospice. So I will leave that part of the story till later if I have time. Yeah.
Okay. Wow. So one of the things you mentioned earlier on is this idea of hospice not being a place. So what does that actually mean? Because a lot of us, and we have a number of questions where they see a hospice as a physical building where people actually go into to be admitted. So it's like a hospital for end of life. Is that accurate?
Yeah, I suppose that's one simple way we explain to patients when we want to bump them off from the hospital to a place, just to clear the bed. Well, not actually. Sorry. I mean, a lot of times, some of our colleagues in the hospital, whether it's oncologists, whether it's some of the physicians who have been looking after these patients very, very well, they imagine a location that has got very lovely people in there with the kindest of hearts who have the skills to be able to manage the physical, the emotional, and the psychological and spiritual issues as somebody is dying. And they actually wanted the best for this patient. And that's where they hope the patient can go to eventually, so that this patient can have a nice ending. So it's one thing that we hope as clinicians that our patients will be able to get at that time when we have nothing else to offer. So and by default, a lot of people think hospice is just that, and wanting something good, and why not? Let's just move the patient to a hospice. So it looks like a heavenly place that has got some medical facilities in there, and then the patient breathes his last with everybody surrounding them. So I think that's how people imagine hospice to be. But really, as I've said, hospice is more than a physical structure. It used to be like this before when it first started, but gradually we realized that many people want to die at home rather than in a hospital or in a physical locality, no matter how pretty that place is, how much love exudes from that place. They want to die surrounded by their own people. Their own people who have been journeying with them, whether as children or as grandchildren like myself with my grandpa, or a place where they bought themselves with their hard-earned money, even though it can be just a simple 2 or 3 room flat that they are very proud of. They want to live and die in that place which is familiar to them, and therefore gradually over time the hospice care that started in a place grew out from that place to involve bringing pockets or packets of care into the homes, as I said, into the nursing homes for those who don't really have a home, into even the prisons, right? So I think these are things that have evolved over the last 30 over years as hospice started 1985 in Singapore, 1969, if I'm not wrong, in the UK.
Wow.
That's the modern hospice movement, and that's that place where Dame Cicely Saunders started the modern hospice movement.
So as a professional, what you mentioned was that we want to give our patients the best possible experience as they approach the end of life. How do they feel about it? I mean, when we recommend that they, as professionals, that an option for them is to go to the hospice. Do they take it as positively as us?
Well, actually, just like there are many types of people, there are many types of patients, right? So no matter how well this doctor wants this patient to face the end, that might not be what the patient wants. So many times we have patients who fight against a referral to a hospice or reject hospice because that's not where they think they ought to be, because they think they need to continue to fight. And therefore, some of these patients think that a referral to a hospice means it's the end, you don't want to treat me anymore, and therefore get very disappointed and can get into deep spirals of, I suppose, low mood and even depression. And that becomes very problematic for the children. And that also sets ourselves up for collusion, which is very common in Singapore, where the kids will tell us, don't tell my father he's got cancer, or don't tell my father you're referring to a hospice. So we've got, some of my nursing and doctor colleagues, when they go to the house, right, they will be stopped at the house before they actually enter the space to meet the patient by the children. Don't tell them you're from the hospice, just say you're sent by the hospitals to come and, sort his problems and treat his pain. We'll deal with the rest. So this is one group of patients that is not quite ready to meet hospice, or are prevented from meeting hospice in the most genuine way or effective way. And yet there are other groups of patients where they are kind of prepared. They are just glad that there is a hospice that helps to look after them outside of the hospital system. In a sense that some of these hospitals have gone in, some of these patients have gone in and out of hospitals again and again, multiple times, right? Every time they go in will be x-rays, blood tests, 1 to 2 weeks stay in hospital, sometimes get tied down to their beds, right? Because they can get very delirious or very agitated in spite of themselves. It's really kind of not what they want to show themselves to be, but really it's the ravages of the disease or sometimes the septicemia that results in that kind of, I suppose, manifestations. And therefore, they want out. But you see, no doctors in the hospital will allow these patients to come out because they are supposed to do all the good things to them. But if there is a hospice that commits to looking after these people at home, then our colleagues in the hospital say, all right, I'll send you to the hospice, and yes, now I can go home and now I can live in a place I want to be. Now I can be surrounded by people rather than have only 2 persons visit me at any one time, things like that. So there are many different types. So some of them embrace hospice as if they have, they're halfway to heaven. And there are some of those that despise hospice and totally shut us out, from their space.
Sometimes there's the patients that shut you out. Sometimes it's the caregivers that shut you out, right? Because they,
Yep.
in their minds, they are trying to protect their loved ones. So I mean, isn't it a conflict when you have to go and treat them? And there must be some situations where they say, don't ask my son, but can you just tell me the truth? What is am I dying kind of thing?
Okay. Yeah. So I suppose, yes, it is. It's an ethical dilemma of sorts. I mean, in the West, this doesn't happen because people just think that the patient owns his own healthcare, and therefore, people don't have problems or issues speaking to the patient directly, in spite of all the, warnings at the door. But in Singapore, in the Asian, culture, it's important to recognize that the patient actually is part of a family network, and we have to continue to work with the caregivers who are either the kids, right, or even the spouse, to ensure that these caregivers will, work alongside us as we render the care that's necessary at this time. And I think our care doesn't, extend to just the patients alone. The hospice sort of care that we're talking about here involves sorting the patients out in terms of comfort and closure, but also caring for the caregiver. And therefore, it's important for us to then navigate that very delicate space, even with those, I suppose, limitations or considerations, right? So, you just have to walk very carefully.
So you do have a lot of conversations with their caregivers as well, because I assume that since they, especially if the patients are back at their homes, the caregivers have a huge part to play. They probably see the patient more often than you as a professional.
Yep. So, and I think it's important for us to remind ourselves that we are merely, people who have just come into their lives, in the recent past, and these people, they have been living together for the longest time, and therefore we have to acknowledge that, even when they seem to be very, confrontational or challenging to work with, it all comes from a very good place. It's really out of love and care that they put these barriers up, and therefore it's our job to then chip at it slowly, understand what lies beneath, and usually it is fear and anxiety on the caregiver's part, and also to help advocate for the patient to bring out that little voice that sometimes get blocked, either because of power, influence, or because of vulnerability. So I think there are many considerations in the work that we do, and really, as I've said, I can't emphasize enough. We have to tread very carefully, come in there with no assumptions, and be prepared to just listen and appreciate everybody's point of view.
When we think about the patients and the caregivers, right? So that's the patient's perspective, and when they have a team of professionals to care for them. So in the hospital, you have different specialists who will see them for different kinds of conditions. when they go into hospice or palliative kinds of care or end-of-life care, is it still the case where they have different specialists seeing them, or is there only one specialist in palliative care? Are the terms I use correct? Palliative care?
Yes. I'm so glad you mentioned the word specialist, because sometimes people think that the people doing, the staff doing the hospice work are like volunteers. So people forget that there are consultants, there are pharmacists, there are allied health specialists like physios, OTs, speech therapists, music and art therapists involved. So it's a whole spectrum of different healthcare providers. So because everybody is unique, because everybody has different, I suppose, needs, right? We need to be able to put together a whole menu of, healthcare interventions provided by different specialists who are committed to use those skills that they have picked up, whether from school or from their training, to render whatever is needed, to meet at that level. So yes, it is a multidisciplinary team, and I think that's the beauty and also the joy and pleasure of working in hospice. It is even more so within the hospice, because I think in hospital I'm not that I'm not sure. I'm very sure there are hierarchical, I suppose, tensions in that whole system. But in a hospice, I like to think that it is a little bit flatter. In fact, where I'm working, I like to think that the nurse calls the shot, because the patient actually is owned by the nurse. The nurse decides who else gets involved, actually drives the care, and she or he. We do have male nurses working in the hospice. Actually, is the first port of call whenever the patient or the caregiver is in trouble, right? So, and the nurse will call the doctor or the social worker or somebody else, either for help or support. And she brings the case back to the multidisciplinary team, and then we all discuss and formulate the whole care package. And then we will take turns to go in and do the needful.
As a palliative care specialist, if that's accurate, what exactly is the specialty? Because that means someone could be specialist in cardio, specialist in respi, specialist in GI. So what is the niche or that you perform as a palliative doctor?
Okay, that's a very interesting question. I'm quite glad you asked this, really, because so many times, whether I'm facing the public or whether I'm facing my fellow professionals or even facing inside myself, when I'm a bit more introspective and when I, come back from a very bad day, I ask myself, why hospice and what's hospice? So if I'm facing the public, I try to describe what I just said in the last, say, 15 minutes, right? What hospice is all about in terms of helping somebody come to a closure when their life takes a turn, to a different path. To my professionals, I think I need to explain to them that we are specialists who are able to render the kind of care that the patient needs at that time in their life. And to myself, I like to think that I understand what the philosophy of hospice is, and I am honing my craft to ensure that I hit all the right buttons, which would be about meeting the needs in the bio, psycho, social, and spiritual realm. So you could say that we have got a breadth of, I suppose, knowledge and skills and experience. We also need to subspecialize, just like in the pharmacy sector. You guys learn about everything, but you've got some people who are very good with oncology drugs. You've got people who are very good with endocrinology drugs, which I cannot catch up, with at the rate that, these drugs come into the market, right? So I suppose even in hospice, for myself, for example, I train in looking after dying children. So therefore, this whole spectrum of expertise, we hope to be able to have a foundational, I suppose, competency, and then each one of us would have a specialized area that we are interested in, that we train in, that we can then render when the need arises. Yeah.
Oh, it's very interesting the the area of specialty that you have chosen. Because a lot of us have this impression that the people who go to the hospice or under this care, they're typically very old people. Yeah, is it true that most people who require such care are old people, or is there a significant group of young ones as well?
So I'm so glad that actually the people who come to the hospice are mainly the older people. When I say older people, I mean adults, right? So in the hospice, I also want to correct this misconception. So we don't look after the geriatric population. We have very many people who are 20-something,
20-something.
30-something,
30.
40-something, 50-something, who are, finishing their life earlier than everybody else, right? So that's what we do every day. And okay, I would say that some of these who are younger they tend to be the hardest to do because of various things. Something called countertransference will be one of them. So I mean, it's very hard for one of my nurses to see someone or to care for someone the same age as herself, or something like that. So I'm talking about then my work with the ones who are much younger, children. So when I say children, I'm talking about 0 to 18-ish. These are the ones that I went away to do training for, and I came back to then set up the service to meet needs for. So Staff Health is the name of the service I started. It aims to look after children who have life-limiting illness alongside their parents. So thankfully, they are a very small group. So at any one time, my service looks after about 800 patients who are under our care, but only about 60-ish are the kids who are 0 to 18. So comparatively, the numbers are smaller, but the problems, the issues we face, the work is no less, challenging.
Is there a particular illness that is more common for people who are undergoing end of life care?
For the adults, more than 21 years old, no question about it, cancer. So despite how advanced in medicine and technology and pharmacotherapy, right? Essentially, and nowadays we've got genetics and various other things in the back. Cancer still remains one of the biggest, killer in our lives, and I suppose it will be there for a long time. If not, this type of cancer, then something else would happen. So I think if you look at the top 10, they kind of shift positions over different decades, right? So depending on what kind of therapies come up. So yes, for the adults, cancer.
Okay.
And
for the kids?
Anybody. It strikes anybody. For the kids, I would say it would be the congenital illness. The ones who die in the biggest numbers are the ones who are born with some congenital anomaly, whether it's something wrong with the heart or the kidneys or the brain, or during the process of giving birth, things might have gone wrong and all that. And those are the ones who will die very early on in life. In fact, the highest rates of death are below 1 year. But actually, we haven't quite gone into neonatology as much as I would like to, but a lot of my colleagues in neonatology look after these patients very, very well. So we don't see so many of these coming to us, actually. They, die in the neonatal ICU a majority of the time, although we are increasingly seeing some of these. For example, the chromosomal syndromes, the trisomies, like Edwards, the Patals, we are seeing some of these. These are the ones who, the parents will either bring home or after giving birth know that they will not live for very long. And we have the privilege of looking after some of these children increasingly more and more in palliative care with the type or the philosophy of care that I mentioned earlier. And hopefully we were able to allow some of these parents to have beautiful memories in spite of the short time that they have with the babies. So for children, the non-cancer conditions would be more prevalent than the cancer. It would be about 80% to 20%. So it's kind of opposite. Yeah? In the adult world, it would be cancer, and 20% would be the organ failures, the neurological conditions like dementia, multiple strokes, and very severe, CNS abnormalities.
Ah, okay. When someone is diagnosed with a condition, is there a criteria before they are eligible for hospice care or palliative care? I mean, it's like, does it have to be like a fixed number of months left based on the professional's opinion before they are eligible for this care?
Oh, okay, yeah. So that's another good question. So it's something that people ask. I think, as I've said, hospice care is something that people think is provided to a patient near the end of life. So therefore, if you're not end of life, then there's no need to receive hospice care. Increasingly, in the recent, I would say, 10 to 20 years, there is this term that we refer to palliative care. Is this something that you are familiar with, Sean?
Yeah, I've heard of the term palliative care, but it's to me and a lot of my friends and the people that I've spoken to, palliative care, end of life care, hospice care seems to be the same thing. Is it?
Yeah. Well, if you ask me, and for the listeners and the viewers here, I would like to say that hospice care is more sort of similar to end of life care. Really, because a lot of hospice services look after patients with that defined period, just before they die, like you mentioned earlier. So for the service that I run that brings, care to the homes, it would be 1 year.
Okay.
For the inpatient hospices, where it's a place where the patients can go, that heavenly hospital, would be 3 months. Okay. In and around 3 months. We could never be sure about these things. And I think that's another topic that we can, spend a lot of time talking about prognostication. But palliative care would be, another way to describe it would be supportive care. So this is something that you can do upon diagnosis. So even though you have just been diagnosed with a cancer that is quite treatable, I like to think that palliative care can bring a lot into that space to help you navigate the system, whether it's to decide whether to go for surgery, to do chemotherapy. And when things are getting very tricky, when you feel like giving up, palliative care can come in to help support you, whether it's psychologically or emotionally, and also offer alternative perspectives in terms of other treatment options and helping you to make some of those difficult decisions. So I think, and of course, some of the symptoms that come together with the treatment. So it is important to see that palliative and hospice care is like a continuum. There isn't a defined, I suppose, boundary between the two. I work in the hospice, but I practice quite a fair bit of palliative care. So take, for example, I do have patients who are referred to us for end-stage renal failure. These are the guys who decided that, they have been declared to have severe advanced, renal failure. And they don't think that, dialysis is something that they want to do for a long time for various reasons, whether it's financial, whether it's fear of needles and pain. So they get sent to hospice thinking that, we will help them to live, quality lives till the end. And then when the end comes, we help them to die. But sometimes after working with them, working with the caregivers, and after unpicking some of these, confusion, we send them back respectfully to our, specialist colleagues in the hospital and say, look, your patient seems to want to start dialysis right now. And then we discharge the patient to hospice. So I often tell, some of my patients who refuse to meet us, in the first visit that, when you come to hospice, you don't necessarily buy a one-way ticket to heaven. We can actually send you back, really. Yeah. So these are some of the experiences that we've had. So
what you're saying is that sometimes it is a choice. It's the choice of the patient to not want to, or maybe they are not able to for some reasons, to get the care to like make a full recovery, and therefore if they don't have the means to have access to that kind of treatment, then they get recommended to hospice care or palliative care?
Yes and no. So they have a choice. Yes, they get sent to hospice. Yeah. Well, I don't quite like that. Okay, no choice, and then now you get sent to hospice. So yes, you have a choice, because we also have experience where we have very young, people who are diagnosed with, say, cancer, fairly advanced, and they make that choice not to have treatment, even though treatment is available.
Okay.
For various reasons. Yeah. Okay. So there are some people who get very hung up with, I need to have, for example, a breast that's intact. I cannot deal with, taking off or lobbing off any parts of my body, for example, for a longer life, because life is not worth living if I'm not whole, for example. So, and some of them have phobia, or had previous experience of seeing people go through various treatments and then end up in a very bad place. So these are the struggles that people have at diagnosis, where palliative care would be most helpful. And then we will help them to, make that choice, right? So, and we respect that choice, in spite of how we feel it's so, sayang, or it's that's a very stupid decision you're making. If I were you, I would have done that. But again, that person's life is for that person to own, and therefore the medical decision is for that person to make. So after that, if the person doesn't want any treatment, then what happens? Is there a reason to continue to see the oncologist, for example, if you're not on chemotherapy? Then you have to move to a different sort of care domain. So I would have loved for this patient to continue to see, for example, the family doctor that the patient had grown up with or had been seeing for years. Why not? And if he or she feels comfortable with the doctor, then just go there, and you don't have to come to hospice. So again, that there are still lots of misconceptions, and I think that patient doesn't need to be forced to take a path just because he or she has decided not to take aggressive treatment in view of cure. So I hope that answers your question. Yeah.
Do you get numb to this kind of feeling where sometimes you say, it's like so young, you really can make a difference, and the patient still chooses not to do it, or not to take that choice. So as professionals, of course, we try to respect our patients' choices. But if that happens again and again and again, do you as a professional feel like even you lose hope yourself?
Okay. I hope I understand what you're trying to ask me. So firstly, I hear that numb part, and then the second part is really about how somebody wanting a particular sort of treatment option against our best of intentions, consistently chooses something that we recommend against. Okay, so numbness, I would say it is something I fight very, very hard not to get into. The day when I get numb is the day when I cannot practice in palliative care and hospice anymore, because I'm no longer sensitive to the suffering that I'm trying to assuage or to mitigate, and I would never be able to get deep into the psyche of my patient or caregiver, and be able to empathize with their situation. And it's something that we need to do the work that we have to do. And then on that second aspect about how there is attention between what we think is best and what somebody wants, against our best of intentions. I would say that, again, coming back to what I said earlier, it's important to understand that unless you've got cancer yourself, at that time you decide, right? But when it is somebody else, what we need to do is then to help that person bring up that voice of his or her, because I think it is very courageous and brave of that person to, in the face of all of these adverse adversities, right? Make that choice. Many people run away in denial. No, the doctor's talking rubbish. I need to go and see another doctor. Either that or just close their eyes and just soldier on and fight and fight and fight. Uh, uh, Really, coming from a place of fear. And I think it's important for us to advocate for that patient by starting to understand where the decision that's made is coming from. Is it a place of total understanding, what we would call informed, whether it's consent or informed choice, and then see what might be some of the larger goals that the patient has that kind of motivates them to choose a particular choice. When we have intimate conversations like this with our clients, we get to see their point of view, and then we will slowly change, our stance. And we can, most times, once we get into that position, I can safely say that yes, maybe if I were you, I will make that choice too. And I think that's that endpoint that I hope to get every time I meet a client.
There are so many things you have to consider. There's so many possibilities, so many aspects, and of course you have to consider it also from what the patient sees, which is what you try to do. Every day you meet different patients, you meet new patients.
Yep.
What's the first thing that you say to someone, a patient or a client that you're meeting for the first time?
Okay. That's a very interesting question. And well, I would say my pickup line would be how's your day today? Something to that effect, right? Either that or it would be, is it a good time for us to have a conversation? And I qualify by saying a conversation, meaning not the medical conversation, because I respect that many times the people that we meet, right, or the times that we go or get into their lives is a time when they are in distress. It's a time when they can be in physical pain. It's a time when they may be full of other emotional struggles, and sometimes in spite of our compassionate place that we come into this space and our passion to serve, we forget that that person might not be ready to meet us, and therefore that opener is very important. So we must ensure that where we are right now, sometimes assuming that this person is vulnerable, we must be able to come down to that place. And it is the same whether the patient is an 80-year-old man, 28-year-old woman, or 8-year-old girl who is suffering from very advanced intractable leukemia and who's dying. So I think it's important for us to be able to come to that place, and that takes a while, depending on where this person is, whether emotionally or spiritually. So I think my pickup line really would be, can I come into your life and know who you are right now? And that's all I wanted to do today. And I suppose if they want to talk, we will talk some more. If they don't want to talk, then I'll come back again.
Wow.
Yeah.
Wow. It gives me a lot of food for thought, because for me the patients that I see are either in hospital, but they're mainly outpatients. So it's a very different kind of group of people, and I very frequently think, or I ask myself, what is the best way to build rapport? And one of the things that we always tell our students is you have to be able to come down to the level of the patient, because especially in places where we have to wear our white coat, right? Because organization says we have to wear a white coat. And our patients already see us as experts or as people up there. So it's very easy to be perceived as someone is trying to instruct me and force me to do what I might or might not want to do. Yeah, so
actually, it's a lot about our own egos, So I think I just want to make this point that sometimes people think that the ones who are working in the hospice are all kind of angelic or overflowing with compassion and the nicest people in the world. But I think we don't have to wear that kind of halo, even if it's true, when we meet our clients. Really, it's just reminding yourself that you are just another person in this world that happens to have this privilege of meeting someone else who's not going through a very good sort of time. And if that person opens his heart to you and grants you some time and helps you understand what's the experience like, it's such a privilege. So I think if you can then hold that, I suppose, thought, right, and then prepare yourself for that encounter, I'm quite sure you have a very fabulous time, a time that you come back and reflect. So I think this is something I learned in the last, I would say, 20 years that I practice in this field, that actually sometimes I think when I go in there to give, I actually come out having taken away so much more. And I think that's something I want to share with everybody.
Okay, thank you. Well, we'll just take a moment to say hi to some of our friends. Lakshmi is here. Thank you, Lakshmi, for joining us. Jane is here, and Jasmine is here. Hello, Jasmine.
Jasmine!
Yes, and Dr. Chong knows Jasmine, I assume, pretty well. You've worked together with Jasmine. And Jasmine was the one who set up this conversation. So thank you very much, Jasmine. Well, Dr. Chong, how do you stay compassionate? Because one of those things that you mentioned earlier is that you have to maintain that ability to feel for someone, that empathy, because it is the core of a lot of our work. I presume even more for your work. How do you sustain that level of compassion? Because even the most passionate people get tired.
Yes. How do I stay compassionate? Well, I think the question should be, how do I continue to work with compassion? I like to say that all of us are compassionate in our own ways, right? And it is something that is within us, every one of us. So if you see a young boy or girl fall down, very naturally you will run towards that child and pull that child up. So it is something that all of us own, right? But if you have to keep picking up that child again and again, and you see every other day another child get run over by somebody or almost get run over by somebody, and you have to grab the child back, it gets tiring. And I think maybe your question is about how do you continue to keep doing this again and again and again. So I suppose it would be about ensuring that we stay grounded, not thinking that what you do is really huge and you're changing the world. You are making the world a better place, world peace and whatnot. No. So it is about coming back again to reflect why you are in there, and what are some of the meaning or satisfaction that you can get from there, and most importantly, the price that you pay. So I would say that doing the work that I do and having those encounters. Sometimes on a very bad day, I like to think that even though I say I take away much more than I give, every time I meet somebody, it's almost like I give a piece of myself away. And I'm just like cutting my own flesh almost and giving it away because it's so intense, the relationship and that exchange that we have in that dialogue or that moments where we connect, that often walk away a little bit broken, lost something. So I suppose it's a game of give and take, yeah. But again, we have to acknowledge that this is something that happens in the encounter, and therefore we need to replenish. Otherwise, after a while, you realize you are, scrapping bones, and you've lost all muscles, and then you start to not bleed anymore. You start to become, as you said, right, numb. Sean, and we all have in our industry through training, and also as now a manager of a big team of people, constant reminders that every one of us, whether you are junior or senior, nobody is immune to compassion fatigue or burnout, and therefore in our daily practice there must be, I would say, almost rituals that we all do to ensure that we rejuvenate ourselves, and we replenish, and we come back, we bounce back whole again. Otherwise, we would never be able to give. And for me, it would be about my own medication. Yeah. Okay.
What are some of these rituals?
Okay. So when I say rituals, it would be about after having met somebody, I would usually spend moments, this introspective moments with myself, asking what the encounter was all about, what happened in there, and what are some of the things that I've given away as a result of, that encounter. So just like this hour that I'm spending with you, it's not quite a therapeutic encounter, but I think I have exposed myself a little bit, and given away something, hopefully for a very good cause. And afterwards, I might have to sort of sit down and either look at the recording or think through what are some of the things that I have, I suppose, given away, parts of myself, my own vulnerabilities, or, weakness or whatever, and then go away and see, okay, how might I need to fill up that vessel again so that I can continue to give every time I meet my clients. So I don't mean to say you are my client, but I'm just using this to compare with the work I do with a particular client. So those rituals would involve a reflection afterwards. It would involve, I would say, not enforce, I enjoy time with my plants in the garden. So in nature, it would involve time in the swimming pool. So, these are the things that each of us individually, we will find ways to recharge and, replenish ourselves.
Have you ever yourself felt burnt out? Like once, any point in time where you're like, I just need a break? Burnout doesn't necessarily mean that you don't think your job is important, but sometimes you're just so tired. Have you ever had an experience like that in your career?
Yes, a few times. So this is a time to be very honest with everybody. It's about because I'm human. Yeah, it's about times when we kind of lose control because events just come. You get swept away by whether it's your schedule, various agenda, different responsibilities, too many things on your plate, and again, living in this world, working within a system, within a larger system, so many things are actually not within our control. And even if you're self-employed, right? Even if you're a freelancer, the world sweeps you away many times, right? So there were times when I felt that I become very angry with myself, and also become very frustrated when I'm asked to go and attend to a patient. And I start to do all the things that I teach people never to do. I start to become, directive. I start to get impatient. So I think I'm just listing some of those things which are really signs of an impending, I suppose, burnout, for everybody to become aware whether you're in a helping profession like myself, and I like to think that all pharmacists are in helping profession too, and you guys also burn out, and to be really acutely mindful that you might just need to go away for a while. So some of those times when I got burnout, I decided to change my career, or I decided to change a place where I work, because again I recognize that some of these things are not within my control. Even how many flowers I get to bloom, how many laps I swim in the pool, it's not going to change my day. I know I have to move on. Yeah. So I need to go to a place which is restorative, which is nurturing, which is empowering. And therefore, I suppose the point I want to make is that you have a choice. You can make that choice to go to a place that you deserve to be.
Wow. Thank you for that, because it's not easy to, well, actually come on live and share an experience like that. Well, speaking about choices, a lot of times, or maybe I would put it this way, one of the things that we were talking about earlier on is that patients do have a choice, right, on what kind of care they want. In your experience, when patients know that they have a life-limiting condition, do they normally choose a higher quality of care or a quantity of life? So it's a quality of life versus quantity, because sometimes to prolong a person's life requires them to go through some medication, some pain, some procedures, which they might not want. What do your patients, in your experience, what do patients typically feel for?
Okay, so I would like to qualify that they are not, on opposite ends of I suppose, a balance, right? Okay, so you can choose very aggressive treatment to enjoy quality of life afterwards, right? So it would be a short-term pain for a long-term gain, right? So I just want to ensure that we're not talking about a dichotomy here of actually embracing comfort and everything else. I mean, if you've got a cancer, you cannot get good quality of life just going out to breathe, fresh air and take whatever diet, no matter what is touted out there, right? You just need to go through the scans, the treatments, the surgeries, the radiotherapies, whatever. So you need to work for what you want. Even for quality of life, you also need to, I suppose, what I'm trying to say here is that, yes, you can make that choice, but to choose comfort is not about being lazy or passive or, giving up. It is about exercising your own option, respecting that you want to preserve something rather than trade off something else for that longer time. And the other thing I wanted to qualify is also if there is a, fighting for, many people would want to go through some of these, very challenging, very aggressive, and I would say difficult, harsh treatments for that particular goal, only if it is big enough. So I have got people who were prepared to drop out of the race, but then changed their mind because they suddenly found hope for something or a purpose for living a bit longer. So I would say it's very hard to tell, whether there are more of these people of this group, but it's rather a spectrum. And I think the only thing that helps people to keep, soldiering on, waking up to, see another day of more treatments or, more surgeries, would be about what is the purpose of living? Why do you wake up every day? Who are you living for, or what is your goal in life? And these are the conversations that we have with our patients to ascertain some of these. And then those are the ones that we will use to help them decide whether it's this or that. So there have been times when people are sent to a hospice, and when we found out that they actually had some other dreams that they were not able to articulate in the hospital system, we did actually, go back to the oncologist, for example, to argue for another trial, for example, or a third line chemotherapy, because actually we discovered that there was a reason why this patient needed to live maybe 3 months longer. And you would have heard of how people wanted to see the daughter go through, I suppose a marriage ceremony, or they want to see somebody fly home from somewhere, and they would fight till the very end. And that's not wrong. So there isn't a right or wrong path, but what's best at the time for that particular person. Are you able to hear me, Sean? Testing, testing. Testing, testing.
Can you hear me? Hello?
Yep, yep.
Now you can hear me. All right, great.
Are you able to hear me?
Yes, I can.
Very
Great.
good. So sorry.
No worries. Looks like we're back.
Yep. Don't know what happened.
You or me. I have no idea what happened as well. Okay, great. So the previous question I asked, I can't even remember. Let me see.
Go to your 52nd question then.
Okay. Let me see.
Are you seeing any questions coming from the chats?
No, I have people saying hi, but can't see a question here. All right, let's talk about the caregiver's perspective. All right, sometimes it can be a difficult decision for them to decide whether or not to, for lack of a better description, to enroll someone in palliative or hospice care, because they feel that it is a very cruel thing to do to send someone there. I mean, it's part of this conception that it is similar to sending someone to a nursing home where there are certain perceptions about it. So, I mean, the question in its actual words are, is it cruel to send someone into hospice care?
Well, I think everybody has a right to their own opinion, and as long as that opinion is a correct one. So therefore, I think it's about helping them to see what this is all about, right? So as I've said, the care that we give is not provided to just the patient, but also to the caregiver. So we do have, that space where we talk about what most caregivers struggle with our experience. And we also have caregivers who would come to us as caregiver volunteers, right, who had enjoyed our service, who then go to our new caregivers to teach them what it was like during their time. I found some of these really helpful, and then these caregivers, perhaps their mindsets would change. So one of those things that I hear a lot in the course of my work is about from the caregivers after they are bereaved, right, when the patient passes away, is that if only I had known you guys earlier, life wouldn't have been so difficult. Why didn't anybody tell me that you guys existed until so close to the end? So it's one of those things that we all see a lot of times, which is late referrals. So we don't get to meet our patients and families until the patient is dying. By that time, it would be about trying to get the patient comfortable. If I might put it in a figurative way, to wrap up, right? So, and that's very little we can do. We don't even know who this patient is. We don't even appreciate where the caregivers are in terms of their emotional status and even what their needs are. And even bereavement care becomes very difficult. So that reminds me. So our job doesn't end after the patient dies. It's also about journeying with the caregiver afterwards, because different people have different experience. Depending on the bond and various other factors. A bereaved person can take a very long time to then get back into the groove, so to speak, after losing somebody, right? So, this is not a good example, but Sean, when you lose your handphone, right, one day, how do you even get over that? Particularly if the handphone is something that is given to you by somebody, or you work very, very hard to, earn to buy that $2,000 handphone. It's that losing something and that attachment to that something or some person, and how to resolve, that tension. So I think all of these are work that we do with the caregivers, and I think if we have very late referrals, we would never be able to do this well, and that becomes problematic.
So what do you think is then the solution, or what do you think needs to change in this area? Because for some caregivers, it's a case of a misconception of what this whole idea is about. For some caregivers, as what you shared, they did not even know such a thing exists. So what has to change for this situation to improve?
It would be about information sharing. It would be about widespread understanding of what hospice or palliative care, for that matter, is all about, and that's the point of your show, isn't it, today? So I hope that today's episode will go viral. and really viral for a very good reason. Not because we want to win the elections, but we want to ensure that everybody who one day, is going to face someone, not necessarily yourself, right? Someone who is struggling in this space, and every one of us would, right? Anyone who is close to us will one day, face that situation. And I just want everybody to know that there is uh, not a place, there is a service that exists to support you. If you want to, if you don't want to, that's fine. And we will come in if you invite us, and give us that privilege to journey alongside you. And I think that's the only way. So don't depend on your doctors to tell you, okay, this is next. Since I don't have anything else I can give you, go and see this person. He will come and tell you how to die, but rather he will come and tell you how to live. But I think misperceptions can be very, very deep, and that's something that needs a lot of work for a very long time. But having been in this space, for more than 30 years, at least in Singapore, I see that we still have a lot of work to do. And I think this little voice here can only make that little difference. But I hope if everybody shouts out, maybe one day everybody will know hospice in the true sense of the word, and would be able to not be afraid and to embrace it with passion.
Well, I think that's something important for everyone to hear. Whether you're listening right now, whether you are a professional or whether you're not a healthcare professional, I think that to be really, really honest, I did not know much myself about what the whole palliative care or hospice care idea in Singapore is. It's something really new to me. And because this was a topic that was requested by some of you guys, that's why we have Dr. Chong here to explain this to us. And I hope that the messages that are coming from Dr. Chong will be shared with everyone else, not just to limited to yourself. So please do share these messages, this video. Please subscribe, and with everyone as well. Okay, so we have a few more questions, and in the meantime, if you do have any questions that you would like to ask Dr. Chong, please feel free to just drop it into the chat because we see everything that you type. Okay, let's take a look at some questions. All right, there is a question from a friend, and she asks, when you have a patient who is in hospice care, and when do they feel a sense of conflict, like they don't know, is it, okay, let me ask the question again. Is there, for a patient who is suffering or going through end-of-life care, do they have a conflict on if they are ill, do they call the doctor or do they call the pastor?
I wonder where that question comes from. And actually, you call both. Well, depends on what you need, really. I think anybody who is in that position can have one of several issues. And it could be all of the above. So you call both, right? So, but if what troubles you is frustration over why me, where's God when I need you most, and can you assure me that I'm going to a safe place because I've been a bad girl, for example? That's, I suppose, a calling for the pastor. And if it is about everything else outside of that, you can call one of us. Call my nurse, and my nurse might decide that, okay, maybe Dr. Chong is the right person to come the next time I come visit you, or I might get my art therapist to come in, or actually I might get my pharmacist to come in and tweak your medicine a bit because you're having wild dreams that bring you to la la land when it's not necessary. Your drugs are over the top. Yeah. So I suppose it depends, really. Yeah. So I hope that answers your question.
Okay. For patients who are nearing the end of life, what are some things that they tell you? Do they have regrets? Do they have thoughts? Do they have reflections? What are some of the most common things you hear from patients who are almost at end of life?
Yes, that's an excellent question, and it's something that actually I enjoy the most. When people are comfortable, when people are at ease or at peace with themselves, and are quietly dying, they start to talk, and they talk with so much wisdom, whether they are young or whether they are elderly, or in middle. Um, and these are the times when I hear the most precious things. So some of these would be about how they believe that they are going to a better place, and they want to. So I've got this young girl. She's about 5 or 6, and I hope I didn't lose you there, because I kind of lost that screen for a while. So, okay. So I've got a young girl who was able to describe very shortly before she died that she could see, Jesus, and the place that she was going to go. And she described it so vividly. And these are some things that is very comforting to not only myself, but most of all to her parents, who just needed to hear that she was prepared, she was not afraid, and she was ready. So, and I heard of some other people who are, this is a middle-aged man that I sort of looked after. This was more than 10 years ago. And I remember it, very fondly. So this was a man who said that he had, in spite of all the very dark and colored past, he used to be in gangs, and he went into prison and all that. He was able to come to terms with his past, and let go of some of those, I suppose, guilt or misgivings that he had, and he felt so at peace with himself. And in spite of who he was, I was able to see in front of me somebody who was so. This was an angel I saw, right? Okay, so this I couldn't quite describe it, and I was able to then see how much somebody could actually evolve over time when. I suppose I wouldn't like to say that I supported that, but I like to think that I created that space for him, and he was able to then get to a space good enough for him to feel ready to move on. He had all his other last affairs sorted. He had his parents, right? He was about 30 something, suffering from colon cancer, which was incurable, and was dying. And he was able to say goodbye to his parents, and face whatever that was happening to him, which was severe to me, with everything popping out from the tummy, because the tumor was just growing out from the tummy. It was ugly, trust me. But he was so at peace, and so ready. So I mean, these are things that I hear. So very many different things from different people, and the older ones usually, I hope most of them are like that, and I see that they are. They all kind of saying things like, I'm this old. I've seen all my kids, my grandkids, and everything else. There is nothing else for me. I'm ready. I want to move on to another adventure. So I think I just citing some of these examples, I hope to kind of excite you in a sense that the world of hospice is not dark and gloomy, and it's all about closure, the end, but really it's the beginning. It's about the value and the potential of life coming to a temporarily, it's not even a pause or a stop, but rather a close of one chapter, moving to another chapter, and it's full of possibilities. So I think these are the inspirations that I got that actually continues to inspire me or to motivate me in my work. And this is one thing I tell everybody who is thinking of coming into this sector, right? You have to be very, very careful because hospice care or palliative care is very, very addictive. Okay, more addictive than the morphine we dish out, because once you step in, you actually cannot stop loving it. And I want to sort of just share this with everybody who's watching.
Wow.
Believe it or not, yeah.
I think it's one of those things where sometimes people ask us in healthcare, how do you stay so long? What keeps you going? It's nice to know that even in a place that is in everyone's mind is associated with end of life, as a professional, you can still go in with that same level of happiness and satisfaction and fulfillment, especially if you spend a little bit more time reflecting on the kind of work that you do and what it actually means to you and the people that you care for. All right, so we're going to take a step back from the patient and the caregiver experience. And this has something to do with the palliative care or hospice care movement in Singapore, all right, or the system. What's the future of palliative care or hospice care in Singapore, especially with telemedicine and technology coming into our lives? Is it going to change hospice care as we know it?
Okay, let me look into my crystal ball, right? Okay, and I think that palliative care and hospice care will not change a lot because it hasn't quite established itself as a fixture. As we've discussed before, there are still lots of misperceptions and misunderstanding of what it is all about. And it has also evolved over the last 30 years in very many different ways. Although it is provided at different levels, I think still many people misunderstand what the spirit of hospice care is about. Whether technology, whether the way the health system changes over time would change hospice, I don't think there would be significant changes. After all, like all things, whether fashion or music, every time, there is always, every so often, there's always a renaissance of some sort. People always go retro. Remember how, mumbo jumbo always seem to be the hottest things in Zouk. For some strange reason, people like to find things they are familiar, they feel comfortable or warm to. And people like to, go back to the essence of what, they actually want. Hospice and palliative care is just a label. Actually, what people want is, a care that is tailored for me, for people to respect me for who I am, and for me to be able to exercise that choice, no matter what happens to me, right? So I think with that, I'm almost like kind of shooting myself in the leg, or actually, getting myself out of a job. In that sense, it is almost similar to anything or everything else that we do in healthcare. So therefore, there is a move, I would say, away from specialist palliative care to, I would say, primary or general palliative care, which I hope would be able to get infused from the tertiary higher institutions to down all the way to every clinician, whether you're a physician, a nurse, or a pharmacist, to be able to understand what it's all about, to be able to live and breathe, hospice and palliative care, because it is actually the brand of medicine that people want. It is actually um, the the style, the spirit of care that people want when you are coming to that time in your life. The needs are so simple. Sometimes when you speak with a patient, all they tell you is, I just want to be able to drink some porridge. I just want to be able to hold somebody's hand. I just want to be able to wake up and open my eyes and know that I'm alive and my pain has gone away, or something like that. So it's very, very simple, some of these needs that we hear. So if you ask me, I would say yes, it is actually moving out from the higher levels, the more specialized, or the more academic or modern technological realm to something more fundamental, more organic, and more real. I think that's where we are headed.
Oh, thank
I
you.
hope.
All right. I'm going to look at one comment. This is from Hui Ting, professor from the university. And she says, thank you, Dr. Chong, for this very informative and inspiring talk, sharing your personal stories and vulnerabilities. I believe many things you've shared is about values-based practice and how to give a voice and hear what the patient wants, and balancing that with caregivers and our professional perspectives. The advice on introspection and reflection is gold. I like the point about how hospice care helps us think about how to live rather than how to die. We should definitely make this notion. What do you think? How to live rather than how to die?
So, sorry, Sean, your question?
Hospice care is about how to live rather than how to die. I mean, would you say that is a sum up of the whole idea of hospice care that we should be getting?
Perhaps maybe you can reword it by saying how to live when you're going to die, rather than how to live versus vis-a-vis how to die. So I would say hospice is very much about how you want to die, right? Except that for a lot of us, yourself included, you don't think you're going to die soon. So therefore, it's not something that you would think about now, but maybe when it's here. All right. So, I like to, as I said, rephrase it. It is about how to live when you're going to die. So I'm just very practical because I don't think any of you are even thinking about hospice, at all, anytime, because it's something that's very far away. Sometimes people even think that it will never happen, particularly when you're 20 something or 30 something. Maybe when you're 70 something, 80 something, you start to think about it. It sort of creeps up on you. So, but for me, because I said I look after children, I look after teenagers, I look after young adults also, it seems to be very close to me. So it's something I think about all the time. Not that I dream every day about how I might die, but rather I become more attuned to living every day most meaningfully and most preciously. I waste no time to sort of enjoy the things I enjoy, acknowledge the people that I love, and meet the people or do the things I want to do. So that is philosophy, not necessarily of hospice, but if you ask me what hospice or palliative care is all about, it is about thinking of how you might want to live if it looks like you are going to die. That gives it a little bit more, I suppose, priority. I'm very pragmatic because if I introduce myself to someone in a normal outpatient clinic and said I'm a hospice physician, oh no, thank you, I'm not there yet. Yeah, so maybe this one looks really costly. So yeah. So I mean, just being very practical.
Thank you for that. That was quite beautiful. Okay, Dr. Chong, it's been 1.5 hours. Wow, time flies. Well, thank you for spending all the time coming to chat with us and for allowing me to ask the questions that some people, when they shared those questions, they say, "Is this a stupid question to ask?" You know, and my response is, if you have the question, someone else would have had the question, and even though some questions were, they were worried whether it will come across as crude, and I said, if you ask that question and you want to know, I will ask the question. And thank you so much for being so open, so vulnerable, and so inspiring, I would say. It's very heartwarming to hear these thoughts, especially for someone who's working with patients who are in end-of-life care. So if you could leave a final thought for some of our viewers, what would you say?
Treasure everything you have right now and love yourself.
That's lovely. Thank you so much, Dr. Chong, for spending time. Thank you, everyone, for joining us. It's incredible. And we'll see you soon. Please remember to subscribe to the channel. If you enjoyed this, give it a like, because it does help us to be able to share this video with more people who have to hear it, not just in Singapore, but all over the world as well. Right. Have a good weekend, everybody. Thank you so much. Bye-bye.